All right, so good morning, everyone. So, as we have just learned the nephron transport physiology, now we will move on towards the renal tubular defects, which are consistent with the mastering concept of the nephron transport physiology. All right. And first of all, before we begin up this concept, let me ask you one of the foundational questions that if we do have a specific transporter, if we do have a specific transporter in our proximal convoluted tubules, and what if that transporter stops working? So what will the urine looks like? So you can just think about this question, and definitely it is going to be look like a sieve, right? And everything that is the transporter was supposed to reabsorb at that time will be lost it, and this will be one of the main concept of our concept of the Fanconi syndrome, right? One of the defect. And what is this defect all about? That this is to be the generalized leakage. It leads to the generalized leakage. And leakage of what? All sort of important things that our body really needs up. So, okay, let's start with Fanconi syndrome. The name might sound a little bit daunting, but the concept is simple. Think of the proximal convoluted tubule as your nephron's bulk reabsorption center, as we have learned previously, right? And what if it is the part of the nephron, the proximal convoluted tubule, where it's supposed to reclaim the glucose, the amino acids, the bicarbonate, the phosphates, the uric acid, and more of that, right? But in Fanconi syndrome, there is a generalized reabsorption defect in this PCT, and it's not just one transporter; it's a widespread dysfunction, all right? And what is going to be the result after all that? The filtrate actually flows through all that filtrate that is flowing through the PCT, but PCT fails to do its job. So all of those precious substances, including the glucose, the amino acids, right, and the bicarbonates, the phosphate, all of the substances, they cannot actually reabsorb and are finally excreted. Okay, you see, the excretion gets more of all these substances because of the defect of the reabsorption transporter in the PCT. Now, how you're going to connect that one alongside with actually that you're looking up over here. So we do have the PCT over here, and we have learned that this reabsorbs all the glucose, amino acids, and all such substances, right? But what if the defect is in the PCT, right? If the defect is over here in the PCT, so definitely the transporter cannot reclaim all of that one. It leads up to the excretion into the urine. Now let's use our physiological knowledge to predict the consequences. Now, because all the things are getting into the urine, right? So can we say that there will be the loss of the bicarbonate? And remember how the PCT reclaims all of that filtered bicarbonate, and specifically via carbonic anhydrase, right? So if that is impaired, we start losing bicarbonates. If the carbonic anhydrase mechanism is not working at all, right? Is not working at all, so we start losing the bicarbonates. So can we say that the bicarbonate level is going to be reduced into the blood and the body leads up to the metabolic acidosis? Yes, absolutely, because the pH goes down, right? And also, this is one of the proximal renal tubular acidosis. This is also to be known as the proximal renal tubular acidosis, and the patient definitely develops the metabolic acidosis. And let's say that now, because there is also the loss of the phosphate, so the patient may also develop the hypophosphatemia. And why is that? Because phosphate, do remember guys, phosphate is crucial for the bones. Its loss leads to hypophosphatemia, and over the time this causes rickets. This hypophosphatemia causes the rickets or the osteopenia, right? And sometimes the osteomalacia in the adult. Osteomalacia, okay? This also causes the osteomalacia in adults, and this is why actually the growth retardation to be seen up in such individuals, right? And you can look up to you see, common due to the hypophosphatemia, right? And the growth retardation is being seen into such patients. And then the loss of the glucose and the loss of the amino acids. So we know that these are the energy and the building blocks in the body, right? So their loss contributes to the overall metabolic stress. Their loss leads up to the overall metabolic stress into the body. And what causes all of that? Well, now let's look up to some of the causes. We do have some of the hereditary defects, for example, the Wilson disease, right? The tyrosinemia, the glycogen storage diseases, and somewhat also to be the ischemia, that is of course lack of the blood flow to the kidney. Okay, and we do also have one of the reasons, what is the multiple myeloma, right, where the lighter change in the body damage the tubules, right, or from certain drugs like the chemotherapeutic agents. These are chemotherapeutic agents, for example the ifosfamide and the cisplatin, and also the antiviral, the tenofovir. And sometimes the lead poisoning in the body also leads up to the Fanconi syndrome or damage to the PCT. That's all what you have to remember it out. But one of the key clinical point, because PCT is also responsible for majority of sodium and the water reabsorption, so the patients with the Fanconi syndrome are more prone to volume depletion. Now, in the examination, they may just simply ask you that why does the Fanconi syndrome leads up to the volume depletion, right? And why does the volume depletion also common in the Fanconi syndrome? So go back to the normal physiology, that the Fanconi syndrome is the PCT reabsorption generalized defect, right? And because of that defect into this one, and the defect into the carbonic anhydrase mechanism, because PCT also is responsible for the majority of the sodium and the water reabsorption, so the patients, they are more prone to the volume depletion as well. Why is that? Because they are losing water and the salt, right? They are losing water and the salt constantly, and because they are losing it of that, leads up to the hypotension, guys, right? So now maybe the examiners, they are not asking you about only and only the volume depletion, right? Probably they are not going to just ask you that what's the link of the Fanconi syndrome with the volume depletion. They may just simply ask you that is that the Fanconi syndrome leads up to the hypotension or not? Hypotension or not, right? Do remember the whole concept in your mind.